So our third speaker is Dr. Jerome Puryear. He received his medical degree from John Marshall University. He completed residency training in radiology at the University of Alabama and went on to complete his fellowships in both neuroradiology and vascular and interventional radiology at Miami-Jackson Memorial Hospital in Miami, Florida. He has several publications and is a diplomat for the American Board of Radiology. He joined Kettering Network Radiology in 2005, where he is Director of Clinical Interventional Oncology. Dr. Puryear.
It's a great pleasure to be able to present to you some of the ablative technologies that we actually use at Kettering Hospital. I will try to be brief. I have no financial disclosures. The ablation technologies that we usually use at Kettering involve radiofrequency ablation, microwave ablation, cryotherapy, and RF coablation. Traditionally, we've thought, or we think of primary tumors, particularly hepatocellular carcinoma, renal cell carcinoma, and lung cancer, when we think about ablative therapies. Since the topic of this symposium is oligometastatic disease, we will be primarily talking about hepatic metastasis, osseous metastasis, and soft tissue metastasis. I'd like to first give a background regarding RFA, the importance of patient selection, our technique, follow-up imaging, complications, and some of the literature. What is the role of radiofrequency ablation in terms of oligometastatic disease? What is radiofrequency ablation? Basically is the use of thermal energy used to destroy tumors. We basically take a needle electrode, introducing it into the tumor under some type of image guidance. That needle is usually attached to a generator, providing current in the radiofrequency range. There are multiple different tines and prongs that can be used to place these into the tumor. These prongs are hooked to a generator, which generates the current. There are three factors that are involved in cell death. Those are the power that's used, whether it's radiofrequency ablation or microwave ablation, the duration of heating, and the distance from the electrode to the tumor. Here's a schematic. Basically, we use high-frequency alternating current, placing that into the tissue via a percutaneous approach. We take the electrode, put it inside the tumor, expand the prongs, and apply the current. That in itself causes coagulation necrosis. This is a complex formula. I've tried to simplify it, and you will be tested on it later. This is a bioheat equation. Simply, it defines for us coagulation necrosis. It takes into factors such as local tissue factors like impedance, electroconductivity of the tissue, the type of energy applied, whether it's radiofrequency ablation or microwave ablation, and the heat loss. The heat loss comes into effect when we're talking about tumors that are located close to blood vessels. If there's a significant heat loss secondary to the flow of blood vessels, that can affect the overall coagulation necrosis. Again, another schematic. Our goal is to get a temperature greater than 60 degrees. The prongs are placed within the liver. The prongs are expanded. We apply the heat through the current, and then we cause ablation of the tumor, and we can cauterize the tract. Cauterizing the tract actually prevents tumor seeding as well as prevents bleeding or minimizes bleeding. We usually think of these structures in two-dimensional structures, but we have to think in three-dimensional structures to make sure that we cover the entire tumor with the appropriate 1 to 2 centimeter desired margins. We usually, in our 3D planning, we take axial, coronal, and sagittal images of the tumor to make sure that we actually have full coverage of the tumor. This is another test question. Can anyone identify the tumor? If you can identify the tumor, you have failed the prerequisite for radiology because there's no tumor present. Here's a tumor that's enhancing in segment 7-8 near the dome of the liver, which, again, we apply 3D tumor localization for access during the ablation as well as our preoperative or pre-procedure planning. Here's another colorectal metastasis, which we actually take the prongs, put them in the left hepatic lobe, expand those prongs, and perform the ablation. Who is the ideal candidate for hepatic ablation? Usually it has to be a solid tumor, less than 3 centimeters, in size. We prefer it to be surrounded by normal liver to prevent bleeding. We prefer it not to be close to vessels, and we prefer it to be not close to the liver capsule or the diaphragm. Most of these patients should be non-surgical patients, and surgery is the preferred treatment. They should have no extrahepatic disease or a limited extrahepatic burden. If there is any sign of infection or liver failure, usually those patients are excluded. We have to take special precautions if the tumor is near a bowel or common bile duct or more centrally within the liver near the porta. So the technique, usually these patients are seen as an outpatient. We do an H&P, get coagulation profiles, look at the lesion size, number, and location, and decide how we're going to ablate this particular tumor, whether we're going to use CT or ultrasound guidance at our institutions. Other institutions use MR guidance, but it's very institution dependent how you will ablate the lesion. But our aim is to really destroy 1 or 2 centimeters around the tumor, and we usually use overlapping ablations to make sure that we cover the complete tumor. The duration of treatment is usually determined by protocol that's usually established by the manufacturer. We try to heat without charring. Charring at the end of the needle usually prevents heat deposition. We can many times circulate saline through the needle to prevent that from occurring. In interventional oncology, we see all of our patients in an outpatient setting. We consult them in initial consultation. We discuss with them whether the lesion will be treated with RF ablation, cryoablation, or microwave ablation. There are certain times with oligometastatic disease we have to decide whether we're going to do chemoembolization or with drug-eluting beads or just bland embolization. That will be discussed at the time as well. Most importantly, we discuss midterm prognosis versus cure. Some of the patients that we see, if cure is the goal, I will make that known to the patient. Many times with oligometastatic disease, that is not the objective. The objective is to have a improved midterm prognosis. I'll discuss with the patient the ablation technique, anesthesia versus conscious sedation, as well as follow-up imaging. Most of our patients with heat-related ablative technologies, we usually use general anesthesia. We can control the breathing, and this provides us more accurate needle placement within the tumor. There are cases where we can use conscious sedation more with cryoablation. It can be simpler to use. With thermal ablation, it is not the preference of choice because the patient is breathing and they can have pain, which makes needle localization and tumor localization much more difficult. We can use ultrasound, CT, or MR guidance. We can use sonographic guidance. It's very fast. It's very expeditious in terms of needle placement. We can assess the vascularity around the tumor, but sometimes it's very difficult to identify the lesion that you are ablating once the ablation starts, and very difficult to identify the kill zone around the ablation. Here's an example where we have a focal lesion within the liver. In your upper right-hand corner, you see the needle going into the tumor. And once the ablation starts, it's very difficult to see the tumor and the margin around the tumor. Sometimes we can transport these patients to CT fluoro after the needle is placed, or we can place the needle in CT fluoro. MR guidance can be used. It is almost real time. It's better than ultrasound in evaluating the margins. The advantage is there's no radiation exposure, but it can be time-consuming and can tie up the magnet. There are some probes, particularly with cryotherapy, that are MR compatible, which can be used if needed. We use CT guidance because it's easy to identify the target in the tissue, it's easy to identify the target zone, and although there is some radiation exposure, it's not that much more exposure than traditional radiation for the initial biopsy or CT fluoroscopic drainages or other things that we perform in radiology. Here's a case where we have a pre-op MRI near the periphery of the liver. We tried to localize it with ultrasound, very difficult to see. We decided to ablate it under CT fluoroscopic guidance. Here's another example, which we thought was going to be a simple case where you have a focal lesion in the left hepatic lobe in your upper left-hand corner. We use multiple electrodes in an effort to try to ablate it, but if you notice right next to that this electrode, there is the stomach is right here. And in trying to move the stomach away, we can put an NG tube in, try to decompress the stomach. That didn't work. Tried to put saline in to try to displace the stomach. The saline went in a different place than what we wanted. Ended up putting a mechanical balloon in to actually separate it and went ahead and did the ablation. So there are several things that we can do in order to completely ablate a tumor. And there's another area here at the top of your screen. There's a CT and a CT and a PET scan that show a focal isolated liver lesion. On the day of the ablation, this was several electrodes were put into the lesion. If you're unsure of the area that you are ablating, after we look at coronal, sagittal, and axial images, if you're not sure that you got 1 centimeter around the tumor for a complete ablation, you can always give contrast to see the area of ablation. If you're not satisfied with the 1 centimeter margin, you can always re-ablate and get a post-contrast study to make sure that you have that area is completely ablated. That was actually the 4-month study follow-up. Usually our follow-ups are at 1 month intervals. We do 1 month, 3 months, 6 months, 9 months follow-up, and then if everything is stable, we can do a follow-up every 6 months and then 12 months. If there's recurrence anytime in that period, we can often re-ablate. Here's another case where RF ablation was performed in the segment 4 lesion that was near the dome, focal lesion here. Immediately post-ablation, we were sure that we got the margin. 3 months follow-up and 9 months follow-ups, you see the area of coagulation necrosis around that tumor. Here's another patient who had a neuroendocrine tumor. They were diagnosed back in 2005, had bowel resection but continued to have symptoms. They had very, very small tumors that lit up on the octreotide study and also enhanced under CT. There's a nodule here. There's a nodule here. There's several tiny nodules here in the retroperitoneum in the perihepatic space. We actually took this patient and we actually performed RF ablation. Very difficult to do, to hit some of these nodules, but we did hit them and the symptoms subsided. What are the complications? Bleeding, pain, skin burn from the pads, which I'll go into a little bit later, infection, tumor seeding, which rarely happens, less than 1% of the time, and any complication related to sedation. So what's the role in oligometastatic liver disease with respect to RF ablation? I'll particularly be concentrating my talk on colorectal carcinoma, since it's the second most common cause of cancer deaths in the United States. 1 in 20 of us will likely develop colorectal carcinoma, and 50% of those that do develop it will have liver-dominant disease. Other tumors that we often see are neuroendocrine tumors. 2% of breast tumors have liver-dominant disease. GI sarcomas, lung, and renal tumors can also have liver-dominant disease. Surgical resection for isolated tumors, 5-year survival ranges from 31% to 58%, and a 0% survival for those without any treatment. The goal of any colorectal metastasis to the liver is R0 resection or complete resection. If that cannot be obtained, oftentimes the patient is placed on chemotherapy, which has about a 24 months survival, and then RF ablation with resection somewhere in between. And looking at the history of overall survival for colorectal tumors back in the 60s to the 80s or so, the overall survival ranged from 31% to 36%. More recently, due to a new surgical technique, that survival has increased to 58%, and one institution has reported 71% overall survival. When we take a look at some of the literature, the Gilliam's reported in 2005 when he looked at 167 patients. He looked at all comers, all sizes, and with various numbers of tumors within the liver, and found a dismal 5-year survival. When he selected those tumors out and had a smaller size of tumors and less number of tumors, overall survival increased in this case. Lencioni, our Italian colleagues, looked at 423 patients, looked at a select number of tumors in the patient, and looked at a smaller number in terms of size. When he selected those patients out for a smaller number and smaller size tumor, overall survival significantly increased. Gilliam's went back in 2008 and looked at 40 patients with a select number of a select size, average of 2.3 centimeters, had a improved overall survival from his 2005 study. So the overall gist of this is that size does matter, and the number of tumors in patients does matter. What factors actually affect recurrence in RF ablation? Tumor size, tumor histology, proximity to vessels, and ablation margin. When you look at local control, tumors less than 3 centimeters are perform better in terms of local control. Those that are away from blood vessels and those with a greater than 2 centimeter margin perform a lot better or have better local control. Tumor histology does matter. Those with neuroendocrine tumors perform better than those with HCC, and those perform better than those with colorectal carcinoma. What's our goal? Our goal with HCC and mainly with hepatic metastasis is palliative. Our goal is to approach that of surgical outcome with hopes of having a lower complication rate than surgery. Patient selection is key. We select those patients who are not surgical candidates and have limited or no extrahepatic disease. Tumor-related factors include those that are less than 3 centimeters, those who have 1 to 5 tumors, all should be ablatable, and those that are not contiguous with larger central vessels. Historically, we look back into one of the major multi-center studies. There was a multi-center study with 41 Italian centers looking at 2,000 patients, 3,000 liver lesions, 600 of those were metastatic lesions. When those were ablated, there was a significantly low mortality of 0.2% and low morbidity of 2.2% in comparison to the surgical mortality at that time. When you look at the comprehensive review of the literature, looking at colorectal metastasis, there were 8 independent studies that were used in patients who had colorectal metastasis that were not surgical candidates. The 5-year overall survival ranged from between 14 to 55%, with the average number of tumors between 1 and 5. There are other studies that have been performed looking at tumors volumes less than 2.5% with a complete control rate near 80%. Tumors that were larger in size had a lower overall control rate. In this particular study, they were unable to show a significant difference in the survival rate based on size or in the number of lesions treated. Other later studies in 2009 showed 5-year survival decreased with tumor quantity and diameter. Tumors 3.5 centimeters or less and less than 3 tumors had a better overall survival than those that were much larger or had more tumor burden. So RFA is the viable option, particularly for colorectal metastasis, a 5-year survival approaching that of the surgical rate. I did not talk about HCC so much, but I did include that in your handout. The control rate for that is around 90-95% for carefully selected patients. It's important to have good technique and diligent follow-up with all of these patients. So what's the role for oligometastatic disease in lung metastasis? Is there a role? I'll briefly talk about the background, patient selection, technique, follow-up, and literature. Lung carcinomas is the second most common site of metastatic disease from extrathoracic tumors. Our goal is really to eradicate the macroscopic disease. Currently, options available to patients include surgery, stereotactic radiation, and I'm talking about thermal ablation. What's the indication for thermal ablation? Usually those are the same indications for surgery or surgical resection. A limited oligometastatic burden, preferably a small number of lesions. The size of the lesion should be less than 3 centimeters or so with a lack of hilar or mediastinal involvement. They should have good functional status. They may be at a high risk for surgery, hence they would be referred to us or stereotactic surgery. Patients who have a good histology, colorectal carcinoma, renal, or sarcoma may also benefit. We can also use thermal ablation for painful palliative lesions, which I'll talk about later in the talk. So currently there's no randomized level 1 evidence for treating RF ablation for pulmonary metastatic disease. We do see favorable outcomes otherwise, so it should remain an option for patients who are carefully selected. Here's a particular case where there's a baseline 2-month and 6-month exam. Patient has a focal tumor, a metastatic tumor in the right lung. Once it's ablated, a cavity was formed, and then subsequently there was some scarring left. We sometimes do see pneumothoraxes and pleural effusions, which usually resolve shortly after the procedure. Here's another case where we have a baseline 1 month, 3 month, 6 month, and 9 month exam. Focal tumor that does have a very small cavity which resolved into a scar after several months. Again, we follow our patients with CT every 1 month, 6 every 1 month, 3, 6, 9 months, and every 12 months, and 6 months following. We get a PET CT to follow up every 6, 12, and 24 months. Here's another case where the patient has had a bilateral wedge resection in 1995. She did not want chemo or radiation treatment, but she did want treatment. We had a focal lesion here in the right. We actually did ablate that with microwave ablation in this particular case with a good success with having a scar in this region. That was the baseline study. She subsequently developed another lesion in the left lung zone. We ablated that area. We did have a small pneumothorax, which resolved with chest tube placement, and that was at the 6-month follow-up. She subsequently had a 9-month and a 12-month follow-up with no change. The 15th-month follow-up, she had a third lesion near the periphery, which we subsequently ablated. So at the immediate follow-up on the 16th month, we thought we were feeling pretty good. All the lesions that we saw were either ablated or had residual scar. About 4 months after that, she did have recurrence again, and is now on chemotherapy. The complications, as I've already mentioned, pneumothorax is the most common. Usually we place a chest tube and aspirate the air. Usually the chest tube is just removed. Persistent leak is rare, happening less than 1% of the time. There are other complications that can happen. I won't go into that because they're so rare. And we'll talk about the Rapture trial, which is a multi-center prospective trial that really, talked about RFA and biopsy-proven tumors. Our focus today is really on oligometastatic disease, so I'll concentrate on the 73 metastatic patients. Lencioni and his group published this, and when he looked at the tumors, he looked at the mean number of tumors that were treated, which were 2.2 in the colorectal carcinoma group and 1.3 in the other metastatic group. And it really didn't matter based on the histology, whether it was a primary tumor or other colorectal tumor or other metastases. The complete response rate was 88%, or near 90% in all those tumors, regardless of histology. They also noted that there was no deterioration in FEV1 at 1 year post-ablation. Another study looked at similar histologies and looking at colorectal carcinoma, hepatocellular carcinoma, metastatic lung cancer, primary lung cancer, renal cell carcinoma, and they looked at the months after ablation, and there was really no difference in local control in the histology with the exception of metastatic lung carcinoma. Same study looked at a univariate analysis to try to determine what affected local progression. One of the things that did affect local progression was the procedure period. Those who had a true oligometastatic burden and were two years out from their diagnosis had a significant improvement in their local control in comparison to those that did not. Those who had contact with their tumor, the tumor had contact with their vessels or bronchus, had a lower local control than those that did not. And those that had larger tumors, in this case larger than 2 centimeters, had a poorer overall local control than those that had smaller tumors. There's a lot on this slide, but basically there was a Japan study that looked at metastasis in 41 patients, a total of 41 metastatic lesions, had a local control rate of a complete necrosis rate of 70%. Lencioni's group, which I just mentioned, had a 88% or 90% control rate. Overall survival was near 90% at 1 year and dropped to 66% at 2 years. Another busy slide, but looking at a Japan group, a larger volume of study in comparison to the Rapture trial, looked at specifically at colorectal metastasis. 3-year survival was 78%, which is impressive, when those patients were clearly and carefully selected with a tumor size less than 3 centimeters with no extrahepatic disease. When those patients were not carefully selected and had larger tumor burden, 3-year survival dropped to 46%. They did have interpulmonary recurrence of 47%, but most of those were from new tumors. Looking at evidence-based basis for evaluation of the literature, looking at RF ablation of lung tumors. It was recently published. 46 studies were evaluated. Over 2,000, actually nearly 3,000 pulmonary ablations were performed, mean size of 2.8 centimeters. We looked at lung carcinoma, pulmonary metastasis, a combination of those. Some of those didn't have histologies specified. The metastatic recurrence rate was about 18%. Primary tumors recurrence rate was about 22%. When you looked at overall survival, For primary tumors, it was about 58% over 40 months. Cancer-specific survival was about 82%. Metastatic pulmonary disease overall survival was 65% at 25 months. When you look at the International Registry of Lung Metastases comparing RFA to surgery, this registry has been going on for a while, as my colleagues have already mentioned. It's basically to assess the long-term resection of metastasis. They evaluated 5,000 patients from a variety of thoracic surgery departments around the country. Their complete resection rate was 60% at 2 years. RF ablation at 2 years overall survival was about 64 to 66%. The advantage, of course, being a low procedural rate and no deterioration in lung function with repeat procedures. So who do we ablate? We ablate those patients who are less than 3 centimeters in size. It's been determined for local control. Those preferably that have less than four lung lesions, and those lung lesions that are non-hilar in location. We prefer to have thermal ablation of lung metastases, best suited for patients with a limited oligometastatic burden with a favorable natural history such as colorectal carcinoma, renal, or sarcoma. But there are some limitations to RF ablation. Because the energy must be conducted through the body, there is a risk of impedance and charring depending upon the tissue and how that technology works. So where does that lead us? Perhaps there's an emerging role for microwave ablation. I'll briefly talk about patient selection, the background, techniques, and literature. What is microwave ablation? You may be asking yourself. It is the use of higher microwave waves in the electromagnetic spectrum of 900 to basically 2,000 megahertz. Using that type of energy causes water molecules to agitate at 2 billion times a second, producing heat, thereby causing coagulation necrosis. It does differ from microwave ablation in that microwave ablation causes a complete circuit, radiofrequency ablation causes a complete circuit, microwave ablation does not. Microwave ablation occurs by creating a volume of heat around the antenna. This causes an active area of heating. With RF ablation, sometimes you can get uneven or irregular heating, which is why we do overlapping ablations when we ablate our tumors. This is an example on the left where you have a radiofrequency ablation. You have a complete circuit. You have the pads that are on the patient's skin, and then the generator. You have a cord that goes to the electrode, which goes into the body. That completes a complete circuit within the body. There is no complete circuit needed, no current circuit needed in the microwave ablation because there's no current flow. It just goes from the generator into the patient, into the lesion. The other disadvantage in using radiofrequency ablation is you have to ablate one unit at a time. There's a switching device that can be used for each probe to actively be active at one time. With microwave ablation, you can use multiple probes simultaneously, getting a more synergistic effect. Power for power, if you look in microwave ablation and radiofrequency ablation, with equivalent powers or near equivalent powers, you get a bigger diameter of lesion that you're ablating within the liver and within the lung. So it's a much powerful tool that we use. Here's the test. Do you remember this equation? Again, coagulation necrosis is what we're aiming to get. It doesn't matter on how the energy is applied and the tissue interactions, whether there's impedance or low or high electrical conductivity. Our major focus is on heat loss. Microwave ablation prevents a lot of that heat loss, accentuating the amount of coagulation necrosis that you get. When the lesion is located near a blood vessel, we have to be concerned that we're not going to get the optimal heating with radiofrequency ablation. This is not the case with microwave ablation. So the summary with microwave ablation, there's no current used, no grounding pads used, there's no heat sink effect, basically. This all results in a decrease in local recurrence with microwave ablation. What do we use? A 13-gauge needle. Place it inside the lesion of interest. This particular case is percutaneously placed within the liver, creating an oblong shape. It sometimes can form a tail. We try to eliminate that by having saline injected through or pushed through this to prevent charring. Here's the ex vivo specimen of the liver, creating a focal area of ablation. And here's the tail that can be created if the lesion is superficial and you don't use the correct technique. Multiple probes can be used causing a synergistic effect. Here's one needle that's used with one size of ablation. When a second needle is used, a much larger ablation is created, and a third needle is used, a much larger ablation is created. So with microwave ablation, you were able to ablate tumors up to 5 or 6 centimeters. You're able to treat multiple tumors at one time, treat those tumors that are close to blood vessels because you don't have the heat sink effect that you have with radiofrequency ablation. Here's we have 3 generators, so we can treat one tumor with 3 different electrodes. Here's the electrode with the active tip here. We carefully place the electrode or the needle within the patient under CT fluoroscopic guidance. We confirm our needle placement. We get our 3D planning, like we mentioned before. We correct if we need to and make any fine-tuning adjustments. And then we get our 3D planning again to make sure that we're in the appropriate place, and we get our 1 to 2 centimeter margin. And then we follow the patient up. Here's a colorectal metastasis to the left lung base. It is close to a lung vessel, and we're able to ablate that area. Here's another neuroendocrine metastasis. We have 2 focal metastases here. We ablate at the same time simultaneously, getting a good overall result. Here's another one for neuroendocrine metastasis. Have a focal metastasis here in the left and the right periphery. As you see, over a several-month period of time, we're able to cause coagulation, necrosis, and retraction of that area. That tumor is no longer present. Here's another case for neuroendocrine metastasis, focal lesion in segment 7. It's hypoattenuation on CT. It's hypervascular here. We see 2 different dimensions of it. It is hot on PET. This is the tumor here, hot on PET. Once we ablate this area, this is a pre-ablation CT. You have a focal area here. We're able to see it in 2 different planes or 3 different planes during the actual exam. This is the area of ablation, 2 different planes, post-ablative study, hyper-enhancing lesion, pre-ablation, post-ablation, complete coagulation necrosis in this area. So what's the role in liver disease? Busy slide. I'll make it simple for you. Back in 2003 to 2005, there were several studies that looked at survival and local recurrence, some of which we compared microwave with radiofrequency ablation, really showing no difference in survival. With some of the new equipment and some of the new generators that were produced after 2008, some of the newer studies did show there was a decrease in local recurrence and increasing in survival with microwave over radiofrequency ablation. There's another study done at the University of Louisville, looked at 270 ablations. Some of those ablations were ablated alone, some had hepatic resection, some had organ resection. Many tumors were looked at was metastatic colorectal, HCC, carcinoid. They looked at ablative recurrence and hepatic non-ablative recurrences. What did they find? Basically, when they matched those to other radiofrequency patients, there was good success with both of them. The ablative recurrence was significantly less with microwave ablation. The ablation time was much less, OR time was much less, and the OR charges and cost was much less in this particular study. So I'll be finishing up with this palliation in oligometastatic disease. Is there a role for ablative therapy? We're talking about the rationale for palliation, particularly cryoablation, patient selection, and RF coablation. Greater than 60% of the patients with cancer develop skeletal metastasis. Most of these metastases come from breast, prostate, and lung. It is a common cause of cancer-related pain and causes significant morbidity and mortality and decreases quality of life. What is the mechanism for cryoablation? We use helium and argon to freeze and thaw. Through a freeze-thaw mechanism, this actually creates direct cellular injury, causes protein denaturalization, and depending upon whether you do a slow freeze or a rapid freeze, the ice crystals can form within the actual organelles. This can cause an osmotic shift, causing apoptosis. This causes direct apoptosis. It can also, another pathway that's believed to happen is there's some vascular injury that results in stasis and ischemia and subsequent necrosis. This mechanism or pathway is a little bit different than the thermal ablation. In the thermal ablation, you don't have antigens left on the cell. There's antigens that are left on the cell which can sensitize the immune response, and I'll be talking about that in a few minutes. The probe is usually a 17-gauge needle, which is placed in the actual organ. Usually renal or liver. You can you can get minus 20 or minus 40 degrees, depending upon the organ that you're ablating, whether it's vascular or fibrous. You can use multiple probes. Here's what's the mechanism of pain relief. We're not really sure, but we think that it destroys the sensory nerve fibers near the periosteum It causes mechanical decompression of the tumor. The tumor actually causes osteoclastic or cell building activity within the bone. We believe that inhibits that. Ice is a natural anesthetic. It decreases pain following the procedure. One of the reasons that we like it because you can delineate exactly where your ice ball is forming and where your ablation is occurring. You can perform this procedure multiple times if needed. Another busy slide. I'll make it simple for you. The GET study was a 2002 study. It was a multi-center trial looking at 43 patients who were RF ablated. They noticed that they looked at pre-pain scores and post-pain pain scores, pre and post-ablation, and noticed there was a significant decrease in pain scores after RF ablation. The Brown study from Dupuy looked at 55 patients, looked at pre and post-pain scores after multiple metastatic bone lesions were ablated and had a 3-month pain-free survival. Basically, you're maybe asking, is there any difference between RF ablation and cryoablation for pain? You can actually use either. Doesn't matter. Who do we choose? Basically, those with painful osteolytic bone metastasis, those who have failed standard therapy or not suitable for standard therapy, and those that have pain originating from a single solitary metastasis. Usually those patients who have pain that are near hollow organs or close to neurovascular bundles or weight-bearing bones are usually not selected. Here's a chondrosarcoma patient with a focal metastatic lesion to the ribs. It's hot on PET. Cryoablation was performed with complete ablation and pain relief in this patient. There's another patient with metastatic renal cell carcinoma to superior acetabulum. Cryoablation was performed, followed by cementoplasty, that is placing cement or polymethyl methacrylate within this area after ablation. 1-year follow-up here shows radiographic stability and continued pain palliation. What are the advantages of cryoablation? Basically, to monitor, you're able to monitor the zone that you're ablating. Multiple probes can be used, and ice, again, has a natural anesthetic effect. One of the disadvantages is that you can't cauterize the tract like you can with some of the thermal ablations, which may be lead your patient more prone to bleeding. And as I mentioned before, there are antigens that are left on the cell, which can cause an immunologic response from the body as a result. It doesn't happen often, but it can happen. What is that immunologic response called? It's called cryoshock, causing hypotension, respiratory compromise, DIC, and multi-organ failure. Probably happens less than 1 to 2% of the cases, but it can happen. How do we prevent this? Usually we treat smaller tumors, less than 6 centimeters. If it's much greater than that, you can break it up into multiple sessions. We can give the patient solumedrol pre and post procedure. What is the role of RF coablation for bone metastasis? Metastasis is the most common tumor in the spine. 30% of the patients will develop symptoms of spinal metastasis. What is our goal? Our goal is really pain relief and preservation and restoration of function. There are several ways in which this can be performed, whether it's with analgesic therapy, steroids or chemotherapy, radiation or surgery, or all other options. But our goal is really percutaneous vertebral augmentation procedures that we actually use regularly in radiology for pain palliation and reducing functional stability. More challenging is that sometimes you can have an oligometastatic deposit in the spine with some minimal epidural extension or some posterior cortical disruption. This can lead to semen extravasation in some of our cancer patients once the semen is put in. So this is more of a challenging role for us in terms of how do we treat it. There is an emerging role of RF ablation with coablation with vertebral augmentation. How is this performed? Well, there's a tumor debulking prior to vertebral augmentation, which can happen in vitro biphasic parametric finite analysis model simulating tumor infiltration into the vertebral body. Vertebral body stability is restored after removing 30% of the tumor and inserting 1 to 2 cc's of cement. This has been confirmed with cadaveric tissue when there's laser-induced thermal therapy, tumor ablation performed before semen injection, showing improved biomechanical stability and reduced risk of semen extravasation over vertebroplasty alone. So basically, when patients present to us with focal oligometastatic burden and a compression deformity, There are percutaneous approaches that we can use to restore the height. We do that by creating a void within the vertebral body and filling that void with polymethyl methacrylate. Here's an example where there's an inflatable balloon that's placed in the compressed vertebral body. That balloon is blown up, elevating and restoring the vertebral body height. The balloon is retracted. There's a cast that's remaining. Within this cast, the polymethyl methacrylate is put in, and then the cannula is removed. What are the advantages? Pain reduction, vertebral body stability, an attempt to correct the kyphosis, and fewer leaks as a result. What are the indications? Someone has a compression fracture, possibly from oligometastatic focus. We usually prefer to do this if the patient has had a fracture within 8 weeks, preferably within 4. We usually only treat 3 levels at a time, and I've already mentioned we use polymethyl methacrylate as our cement. Here's a patient with breast cancer with a focal metastasis to T11 and T12. We actually put the cannulas in both vertebral bodies, blow up the balloon, creating our cavity, and we have some height restoration on T11, but she got significant better with her pain palliation as a result. The last topic is coablation. What is coablation? Is bipolar plasma-mediated tissue dissolution. It basically creates a void by molecular dissolution process with minimal heat deposition in the vertebral body. Basically, it's a type of ablation within the vertebral body. It allows us to remove the tumor prior to placing cement, which decreases the risk of tumor displacement into the epidural space or into the bloodstream, and improves cement distribution. So what are the candidates? What's the algorithm? Basically, those patients who have no cortical disruption, have a vertebral body compression fracture secondary to oligometastatic disease. They have no epidural extension. We just perform conventional vertebroplasty or kyphoplasty. We always get a CT, probably and most often an MRI to accompany that, because sometimes patients will present with one fracture. They may have other fractures that are not detectable with CT. For those patients that have a paraspinal soft tissue extension that may be amenable to a radiofrequency or cryoablation, we will ablate those and perform subsequent vertebroplasty or kyphoplasty with that. For other patients who I've just mentioned have cortical disruption or epidural extension, we can do a coablation with vertebroplasty or augmentation. Here's an example of coablation with vertebral augmentation. There was some minimal epidural extension. This disruption of the posterior margin of the vertebral body. A wand was placed within, causing some ablation within this area. We put an intragraded catheter or balloon in to create a space, and then we fill that space with polymethyl methacrylate. Our topic today was mainly on ablative therapy for oligometastatic disease, but there are other types of liver-directed therapy that we can use that were not discussed due to time constraints, but they include transarterial chemoembolization that can be coupled with local ablation therapy along with drug-eluting beads or Y90. We do believe that it requires whatever approach and whatever tools we use, we believe that it requires a multidisciplinary team approach, particularly with interventional radiology, medical oncology, surgical and radiation oncology, as well as our supporting staff to provide our patients with the best quality of care. In conclusion, RF ablation for colorectal carcinoma hepatic metastasis is an option, particularly for non-surgical candidates. The overall survival does approach that of the surgical resection rate. RF ablation and other hepatic metastases are an option for specifically selected patients. RF ablation is a viable option for lung metastasis in specifically selected patients. There's an emerging role for microwave technology, that role is promising, and ablative therapy can be used as a viable option for pain palliation. Thank you.
Questions? Are there any questions for Dr. Puryear? Are there any general questions?
Thank you for your very nice talk. And I'd like to know what happens to the tissue, which is 5-6 centimeters large, metastatic tissue, that lump becomes ablated, becomes liquid. Where does it go?
It becomes necrotic. It
So what happens to that necrotic tissue? Remains in the lung or liver, or where does it go?
Resolves and becomes a scar.
And drains out through
Yeah,
the
through the normal
venous or
lymphatic drainage,
lymphatic
right.
system?
Right.
Thank you.